Thank you very much. And it is so amazing to come to these things and see people that I have cared for, and then to have someone say, "Hi, Dr. Maluccio, you operated on me," and look as good as she looks. I'm like, sweet Jesus, she should just spread the card around. So my talk for today, I was going to talk about liver-directed therapies. And so just so that we're covering all the things that you may be talking about with your physician, and I think what all of us would agree when it comes to a multidisciplinary clinic or a multidisciplinary tumor board is that you do have all of the voices at the table, and all of those voices have probably a very similar approach to patient management. It's just more that we're trying to slot people in as appropriately to these therapies. So then if you're familiar with all the therapies, then you know what questions to ask, and you understand then better why we're choosing a surgery or a chemo or a liver-directed therapy. So and I don't have any disclosures. So the objectives of this talk for me were to clarify what is liver-directed therapy and why it's an important component of multidisciplinary net, define what types of treatments fall under liver-directed therapy, establish factors that weigh into what methods are used, and then the emerging LDT techniques, because more and more people are interested in where histotripsy is. We've treated a good number of people with neuroendocrine, so I can't put that in perspective for you. So just as she has her red hat, which I had forgotten about her red hat, which is so adorable, except that now none of us with neuroendocrine want a Ferrari. So, so my thing, if you were to ever see a video, and if you've ever been one of my patients, I really approach a neuroendocrine very similar to a car and a parking spot analogy. And so if you think about these cells, her red hat, my parking space, is that a lot of what we're trying to do is use that parking space to direct therapy. So the receptor is the parking space, and a lot of the therapy that we are delivering is going to be directed by a car moving and or honing to that parking space. So if you think about somatostatin receptor analogs, it is just like injecting you with a bunch of little cars that are searching for that parking space. They land on that parking space, and like a police officer putting a boot on that car, it's trying to cripple that cell. It's trying to minimize the chemicals that are produced that give people carcinoid syndrome, and is trying to mess with the mechanisms by which these cancers divide. So as long as you have enough cars clogging enough parking spaces, you can actually delay progression of disease, and it is clearly associated not only with a delay in progression, but overall survival. PRRT is using the same concept, except that we are taking the car and we're putting a radiation particle on top of that car. It is also going in your vein, just like IV fluids. It is driving all over your body, searching for the parking space. It is sucked out of your bloodstream based on the hotness of the cell on that somatostatin receptor PET. And it is damaging the DNA of the cell. So it is also a directed therapy, but it relies on that receptor, and I think was not brought up, but what I think people were asking questions about was oftentimes the higher grade of the tumor, they will lose the somatostatin receptor, and therefore we are less likely to be able to target the somatostatin receptor with therapy. And then surgical resection is like taking your shovel, that's, Rose and I, is you take your shovel and you go out and you dig the weed out of your lawn and you have a big divot in your lawn. But that it is highly effective, and as Dr. Rose mentioned, is if we can meet certain endpoints, is associated with a survival advantage. And then how we know where a targeted treatment is going to go is the PET scan that we use is really just the same little car. It's got a pizza delivery light on it. We infuse it through your vein. It drives all over your body, binds to the same receptor, and sends off a signal. So the way that we know where that radiation is going to go is the car that we use for the PET scan is the same exact car that we use for PRRT. And then we come to liver-directed therapies. So liver-directed therapies, the analogy that I use is it's going to the state fair with your little air rifle, and you're going to the arcade, and there are targets. And then the interventional radiologist can use the unique segmentation of the liver to direct therapy almost as close to that target as possible. So when we are literally driving the catheter all the way right up to the target so that you just hit the target and none of the good liver, we call that a super selective embolization technique. They can then pull that rifle back or pull that catheter back and shoot from a larger, from a farther away, and try to get more targets with the same, air pellet or whatever it is, but that in general, we do not choose liver-directed therapies like a little 5-year-old going to the arcade just randomly, shooting it, because then you're going to miss the targets and you're going to get more damage to the background liver. So the liver-directed therapies fall into a long list, of which the most commonly employed is going to be embolization, of which there's a bland embolization, a chemoembolization, and a radioembolization. The analogy that I use for that is it's like a marble, and you're going to paint glue on the marble, and you're going to roll the marble through sand, but obviously it's not a marble. It is either a silicone or a glass bead. And the sand in radioembolization is going to be a radiation particle. In chemoembolization, it is a chemotherapy particle. And then bland embolization is just the use of multiple different sizes of a balled marble. In general, neuroendocrine subspecialty centers are not too keen on using radioembolization in patients where we would think that PRRT is going to come down the line, but that we do use radioembolization in patients with higher grade tumors. Radiofrequency ablation and microablation, I will go over this. We really don't use cryoablation, but I wanted to make sure I was making the list thorough. Stereotactic radiotherapy is when we use the techniques that are often used in the brain to treat individual tumors within the liver. Hepatic arterial infusion pumps are also liver-directed therapies that are highly unlikely to be used in neuroendocrine. Irreversible electroporation is using electrical waves to kill tumors. And then the emerging technology of histotripsy uses high-frequency ultrasound. I do think it's important to just go over some definitions so that you are just a little bit more educated when you're having a conversation with your physician, and potentially being able to ask questions relative to your unique case. So when we define in cancer care something done with curative intent, it means that the procedure that we are prescribing for you is meant to give you every opportunity to be cured of this condition, diminish the extent to which you can have a net specific event. So there are going to be cases of someone with a mid-gut primary with maybe some lymph node involvement, and Dr. Rose goes in and takes it all out. That is done with curative intent. But a lot of cancer care is done with curative intent. Pancreatic cancer is also done with curative intent, but that doesn't mean that you won't have a cancer-specific outcome. That's what we call recurrence. So, but that the point of the operation or the point of the treatment is to try to eliminate it to the best that we can of having this be a factor in the rest of your life. And that is a very valuable tool in neuroendocrine. Palliative intent is meaning that whatever we're prescribing is meant to alleviate symptoms related to the condition, diminish the side effects related to anticipated progression of disease. So you may not have the symptoms now, but we're concerned that growth in that area will give you significant symptoms that are going to be difficult to treat. And then the success of the treatment is not necessarily measured in quantity, but it is in quality of life, or our success at alleviating that symptom. A lot of what we do in neuroendocrine is done with palliative intent, but I want to reassure you that quantity of life and quality of life are often linked. So it's not as if we say, oh, we're doing this with palliative intent, you will not live any longer, but we're trying to just improve your symptoms. Oh no, is that it can also be associated with prolongation of life, which is the next one. So prolongation of life, which is a lot of what we do in cancer with chemotherapy, with radiation therapy, is when there is evidence to suggest that taking a certain treatment strategy, be that with surgery or liver-directed therapies or chemotherapy or PRRT, is that you are expected to live longer if we were to take that path than if we take a different path or don't take any path at all. So why is liver-directed therapy important? If you were to look at what causes neuroendocrine patients to succumb to the disease, a lot of the times it will be our inability to control that site. So controlling the liver, even when you have disease that is outside the liver, is extraordinarily important. Carcinoid syndrome is often driven by the extent of disease in the liver, and so things done with palliative intent will also be to drive symptoms down by treating the component of the disease that is likely driving those symptoms. And then some liver-directed therapies are considered as good as resection in tumors up to 3 centimeters, and so therefore it's really important to understand whether or not you fall into that category, because if we can save you an operation and do a less invasive procedure, that would obviously be a better recovery for you. And then LDT can be used alone or in combination with other treatments, and they are excellent at reducing the disease burden in the liver. So liver-directed therapies have been used to treat this disease in some way, shape, or form for probably over 50 years. And so for decades, we have a lot of data on liver-directed therapies. So the types of liver-directed therapies, I already had it written for you, is going to be embolization, ablation, and then targeted radiation. So embolization is that if you think about how the liver forms in fetal life, you have these 8 sections of the liver that, no lie, seem like they're just floating around before life begins. And then somewhere in the first trimester, they all merge together, but that each one of them has their separate blood supply. And so they come together into this very complicated 3-dimensional organ, but the innards, the internal structure of the liver remains the same. And so an interventional radiologist can exploit that, because tumors will then be within certain segments of the liver, and the interventional radiologist winds his way around the liver and can direct therapy as close to those tumors as possible. So these are just going to be some examples of that. So if you were to look at tumors over here, this is just in the left lobe of your liver, and so there he's going to go in and he's going to try to direct the therapy as close as possible. And the whole point is to, with certain techniques, you're trying to just ultimately cut off the blood supply to the tumor, and these tumors are highly vascular and therefore very dependent on that blood supply. This is what it looks like when they're doing the little thing. So they put the catheter in there, and then they shoot a little study, and then it literally lights up like a light bulb, and so they can then shoot the therapy through here into these things, and then ultimately, depending on the nuances of the operator, but ultimately you would like to shoot a study after you have delivered your therapy, and you would no longer see that blush there. And so these are just what the particles, they're going through the artery. The beauty of the liver is that the artery is usually what the tumor needs to survive, whereas the nutrition that is coming from your intestines and nourishing the liver is coming through the venous circulation. And then this is what it'll look like afterwards. That same tumor just looks sort of like a burnt out thing, and so it loses its vascularity, and the expectations are quite good. So you get high objective response rates. Almost 80% of people will have a short-term objective response rate. It drops a little bit at 6 months, but people that have durability or have evidence of an ongoing response to therapy at 6 months, liver-directed therapies can lead to long-term, meaning many more months to years of time where you don't have to retreat the tumor. So the expectations with embolization, if you go back to my car and parking space analogy, is that ideally somatostatin receptor analogs, as long as they have a disease burden that is hot enough on the PET scan and they have saturated enough receptors, it is a strategy that can be least invasive and last you a long time with a single injectable therapy alone. But if you have too many receptors, you have too much disease, it would be unrealistic to think that a single dose of that drug is going to be able to control that extent of disease. So cytoreduction, whether or not it be surgery, which is Dr. Rose talked about, or liver-directed therapy, is highly effective at diminishing the total number of parking spaces that would be available for the injectables, and therefore the SSRA is more likely to keep that remaining lower volume disease in check. So 80% objective response rate. When someone says there's an objective response rate to chemotherapy or radiation therapy or liver-directed therapy, that means what are the chances that on a post-procedure imaging you will have a greater than 30% reduction in the tumor, or in some cases we use a different criteria and look at vascularity, but that we have definable things where we say objective response is this. 80% is a great objective response, which is why we will often, with liver-dominant or liver-only disease, rely on liver-directed therapies. High objective response rate, highly successful, many decades of experience. A 52% durable response rate at 6 months. That means that if I were to march every single patient to the 6-month mark, how many people would still have the imaging show a durable objective response? 50-50 is still quite good when you compare it to other therapies in cancer. So 50% is quite good. And as I said before, if you're in that 52%, that durability of that response can last you a number more months and years without needing any additional therapy. So liver-directed therapies are great. Now, the durability of the response, if you say, okay, well, Dr. Maluccio, I'm not as concerned about like the 52%. What are the chances of me being in the 48% that would not have this last me, long term? And you would then go into the same factors that we all talk about at tumor board, which is going to be the size of the tumor, some of the awkward locations of the tumor, but also grade. Grade is about acquiring survival mechanisms that aren't necessarily as limited to a receptor or to a somatostatin receptor mechanism that is, and you may have survival mechanisms that are able to then just continue to work around whatever you're trying to achieve, including liver-directed therapy. So the grade of the tumor and the size of the tumor are probably the things that most commonly result in being in the 48% as opposed to the 52%. And then it is awesome at controlling symptoms. Probably the strongest evidence in liver-directed therapies and embolization is in the control of carcinoid syndrome. It can drive down the serotonin levels and significantly improve the intestinal manifestations of the disease, flushing, diarrhea, and just the lightheadedness and the awkwardness of having those carcinoid syndromes. Complications of embolization are also well established. We call it a post-embolization syndrome. People can have fever, nausea, abdominal pain, fatigue. Dr. Rose did mention that there will be circumstances where people are at higher risk for infectious complications. We have very well-established antibiotic protocols to deal with some of that increase in infectious complication rates. But for the most part, you could have probably almost 2 weeks of feeling really crappy after an embolization. So your investment in the 80% objective response rate can be feeling pretty crappy for around 2 weeks with just overall malaise, fever, and nausea. And then liver abscess is the one where we have, especially in larger tumors with high objective response rates, you have a lot of happy going to very, very unhappy tumors, and that leaves just a lot of kind of debris in that tumor in an area of your body where you have natural bacteria that can lead to increased infections. The types of cases that are good for embolization, I feel like I'm repeating myself, the people that have really bad carcinoid syndrome, I will treat someone with carcinoid syndrome regardless of whether or not the somatostatin receptor analog is working to control their disease, because I think it is far better at controlling carcinoid syndrome in the longer term. Definitely if you have things like elevated VIP and gastrin, because the elevated gastrin and gastrinomas can cause significant downstream consequences with ulcerations within your intestinal tract, and so driving that gastrin level down is super important. And then VIP is one of those that gives you massive diarrhea that can lead to electrolyte disturbances, hospitalizations, IV fluid disease. And so there are times where, regardless of the extent of disease, regardless of if we can't remove the disease effectively to control those symptoms, we will use embolization. Multifocal tumors are very good, and then larger tumors that have a more mature blood supply, very good for embolization. Thermal ablation is when we're just heating the tumor to death, and so there are going to be certain nuances to thermal ablation. I put 2 on there, even though I think for the most part we have shifted all towards microwave, predominantly because it's easier and more predictable. Radiofrequency is just heating those tines up using radio frequency, and so all of these tines will then have a little like heat things of it, and so the placement of that in the tumor in order to get a spherical thing is just it's just a little bit harder for the interventional radiologist. And there are some disadvantages of radiofrequency ablation when it comes to marginal recurrences of tumors, and so a single probe microwave is just that came out, and it's just an easier tool. I don't want anyone to think that if someone's offering them radiofrequency versus microwave, it really matters that much. In the hands of a good interventional radiologist, they will be able to use both effectively. Cases that are good for thermal ablation are going to be the smaller single tumors. For microwave, you can use multiple probes for larger tumors, but it's not good for things that are close to large vessels, bile ducts, or intestinal tract, because you can't control the heat. So if you're right up against a critical structure, like a bile duct or the thing, it will burn a hole in the adjacent structure. So there are going to be some standards of care that are saying yes or no on whether or not you can use a thermal ablative technique. And then the vein issue is because the heat dissipates, so as it's going to get to that vein, the vein's going to suck in a lot of the heat, and so you will get an inadequate ablation on the part of the tumor that's close to the vein. So in general, we just avoid using ablation when we think that there are going to be some reasons we would be less than successful, because I just told you we have like a number of options in liver-directed therapies. Irreversible electroporation is not actually used that commonly, but I wanted to bring it up because UAB is a very well-resourced institution, so they probably have it. We don't have it, so therefore I don't bring it up with patients. Irreversible electroporation is using electrical current. It's really, honestly, like blowing holes in the membrane of the cell, and so the cell then loses it's almost like, I guess, blowing holes in your skin. It loses its ability to protect itself and just dies. It is extraordinarily good. Irreversible electroporation for Dr. Rose and I 10 years ago was painfully complicated, not even worth it, and we lost enthusiasm really quickly because you needed to place these two probes like perfectly together, or else you got an error, and we were like, why the hell am I doing this? So now they've gone to single probe application, and so now it's almost as easy as microwave without some of the complications. Personally, I don't know how he feels about it. Less interested in it in neuroendocrine, way more interested in it in like locally advanced pancreatic cancer, which you guys don't have. But I wanted to be complete in case you guys wanted to ask any questions about it. And then SBRT is using just targeted techniques. So we think about radiation. It used to be given like a box. You had this one and you had this one, and then everything in the box got radiated equally. That's just not the case anymore. Now we have a number of very highly sophisticated techniques to really hone it down, like a Star Wars movie. So SBRT are the techniques that we often will use in the brain. Now we can use them in the liver. There actually have been phase 2 trials, meaning effectiveness trials, using SBRT in secondary tumors of the liver, for which neuroendocrine was going to be some component of those trials. SBRT is on the NCCN guidelines, and so therefore there may be reasons, especially with some location issues, where SBRT is an excellent option if you're just trying to get rid of a single tumor. And then the limitations of SBRT is kind of similar to the heated ones. You can't do it near the stomach, colon, or duodenum, or you will get radiation toxicity. And then lastly, histotripsy, and I hope that for the histotripsy community, I will be the voice of reason when it comes to some of these emerging technologies. I do want to tell you that I am extraordinarily enthusiastic about histotripsy in neuroendocrine. I am more interested in it in the base of the mesentery, where we have some very complex issues with patients with tumors in awkward locations that are likely going to lead to problems, but the operation required is extraordinarily complicated. I am less interested in using it in neuroendocrine in the liver, although we have done it in close to 60 cases now. I'm just more than happy to answer questions about some of the, maybe some of the, not misinformation, some of the maybe embellished information that is currently available on the internet on the value of histotripsy in any particular case. So histotripsy is an awesome concept if you think about it. So we all understand lithotripsy. Lithotripsy is where you're using a jackhammer to break up a calcified kidney stone. And so it's a low frequency pulsed ultrasound, and that's exactly actually what it sounds like. It's got like a boo 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 when you're getting your kidney stone. And then you have something called HIFU, which is, this is a horrible analogy, but I feel like it's like starting the fire with a magnifying glass and the sun, and all you're trying to do is use ultrasound to heat the tissue up to really, really high levels, and then you're just literally boiling it, to death. But the use of ultrasound to reverberate tissue is well established. Histotripsy is a high frequency but pulsed ultrasound that takes away the heat. It's not radiation. It's not thermal, and so therefore you don't have a lot of the limitations. So I give this company a lot of credit, is that they saw the limitations on ablative techniques, and they have now nuanced ultrasound waves in order to treat tumors effectively. And it's gotten through the FDA. It is FDA approved for tumors in the liver. There is no doubt it's going to be FDA approved for tumors in the kidney, and it is extraordinarily well tolerated. So the process of cavitation, and where all the hoopla is on the internet, is the process of cavitation is like you're reverberating, you're shaking the cell to death. It loses its membrane. It goops out, but all the goop from the inside of the cell is obviously can't survive because it just lost its skin, so it lost the membrane, but that it's not dead. So it's almost like giving a vaccine that is a live virus vaccine that's been inactivated. So we understand that concept because then your immune system sees the mutated mutated virus, and then you can mount an immune response for it. So then the whole point is that it's the immune response that can give you then this abscopal effect that is well beyond just the hitting of the tumor. And I think it's an awesome concept. I do have one case where I think we might have said I can say that she may have had that happen, but that we don't yet have the ability to determine who would or would not get that effect. That's something that we are working on in the lab. So it is non-thermal, non-invasive, and it's got a lot less adjacent tissue damage, and so extraordinarily well tolerated. We have not had a single patient in our 60 patients have a problem. So this is just the case example, so you can look at the extremes. I have a case example where I think it was great, and I have a case example where we had to pivot almost immediately to embolization. So this was a 77-year-old woman who has been heavily treated. She was actually on the news, and she had a G2, so that's a higher than average grade, but she had lived a long time with slow progression of a disease, and she had almost had a point in time where we had honestly had to take almost everything off the menu, including chemotherapy. So she was having stable disease, but worsening carcinoid syndrome. But worsening carcinoid syndrome, she had carcinoid heart disease, so she really wasn't a great candidate for a lot of the other things. She was having lightheadedness, near syncopal events. She liked to swim, and so therefore she would go into the coldness of the pool, and then she practically fainted in the pool. You can imagine the 77-year-old lady at her jazzercise class in the pool, and she's like, practically going to drown. And so it was just really, I think, a slap in her face on how this disease was ultimately going to rob her of the things that she liked to do. So I said, well, you lose very little because this is a very well-tolerated, least invasive thing. But I'm going to tell you that I don't exactly know what you gain because she has multi-organ site involvement, including bone. So her serotonin level has risen to around 1400. We opted to do this. It is what she wanted. So this was our treatment plan. So in patients where I'm using histotripsy to better control carcinoid syndrome, which is really what liver-directed therapies do, regardless of the one you chose, I went with the one that was the hottest. And I went with the hottest because that's the one that's got the most parking spaces, and therefore if you then have enough things binding on that thing, those are the cells that may be contributing at most to her symptoms. So I just hit the hottest one. So I have this one here, it was super duper hot, whatever, and then this is what it looked like 3 months post. So clearly, if the way I described that, the planning of that procedure for you is that you do have to be under general anesthesia, and that's because you can't move, or it's like shutting off the car wash, is that you are trying to then get this ultrasound in position, and it's like locking your car into the car wash. Once you're locked in, the beam will do what it does, and as long as nothing moves, then the beam will only hit that area. And you can go as close to a bile duct, a blood vessel, it does not matter. And the thing is that if you move, whatever, it's not going to injure those things, it's going to shut off the machine, just like if you move in the car wash, it's going to shut off the car wash. So this is post, and so this is what it looks like. But I'm just going to let you, a lot of things look like that. Embolization looks like that, ablation looks like that, but that's just reassurance that we hit the target. And then the follow-up was that her serotonin went down and she didn't need her rescue shots. So for her, in her mind, she was just like, oh my God, this is like the best thing ever. So going on the news and saying that was probably then a lot of misinformation for all the other patients, because then I had honestly 100 people want it. So, but that in her case, it was I didn't have good options for her. I didn't think that the strain of embolization, there were a lot of reasons why I didn't really want to go a big or go home on her, and this just happened to work really well for her, so I'm super happy it did. It's just that for one person, you can't do something in 60 people if ultimately you think that it super duper helped one. It's not that it hasn't been fine for the other people, it just probably hasn't been as fine as this one. So she has had a stable disease and she's had a durable response in that lesion. And then, but this is what her thing looked like. And so I think that this is when I'm trying to be fair to all my neuroendocrine people, because they're going to say, well, I could make my images look like that too, Mary. So this is just what she looked like before. And if you were to look at just the durability of her response and her ongoing stability of disease in someone that was having slow progression for the last 3 or 4 years of her life, I do find it hard to believe that my hitting one tumor in her liver could have possibly all of a sudden had her disease decide that it was just not going to do very much if I didn't have at least some aspect of a more diffuse thing. So this is the only case in the 61 where I felt that I could have said, hey, maybe there was going to be some component of histotripsy that helped her beyond my hitting that one tumor. And then I'll do these fast, Michael, I promise. So this is just one that was less successful. This is a woman, once again, long-standing, a number of treatment options had. She had embolization before. She preferred this as the less invasive option, but she had grade migration. So the one term that we did not use, but I think was coming up in some of your questions, is that you can have a disease over a long time, and you can have one tumor that becomes like the ugly cousin version of thing, and we consider that likely grade migration. It will lose its somatostatin receptor avidity, more likely to then pick up FDG avidity on the other type of PET. So this was a patient where we felt that she had grade migration. So this is her tumor here that is still hot. This one, which was previously like lower level hot, lost its hotness, and so we predicted that that was likely going to be a higher grade tumor. We ended up then biopsying that tumor. It was a grade 3 well differentiated as opposed to her lower grade tumors before, and so I said, well, I should be able to just target that tumor. But that her 1 month post, I mean, I don't think it looks any different. I mean, if anything, I feel like it looks more solid. So incredibly disappointing, because I did this similar to what I would have done with thermal ablation. I'm trying to eliminate a bad acting tumor, and it was really very dissatisfying. I pivoted very quickly in her, regardless of the fact that it's not like it had grown, but that I felt that we had then delayed more definitive therapy. We just embolized her last week. So I think that as long as we're able to pivot very quickly on the people that are less successful, I don't believe that we are in any way hurting people with histotripsy. And then the abscopal effect is just the ability to get a immune response that's beyond the targeting of one treatment. So in summary, liver-directed therapies are a standard of care method to treat metastatic NET. The expectations of response are extraordinarily high, and it has been around for a number of decades. The grade of the tumor is less relevant. You can still get an excellent response rate. I have actually used it commonly in combination with systemic therapy in patients with higher grade tumors to better control the liver. It can be used alone or in combination, and the tumor location is the main factor that limits the ablative methods. And I think that's it.